So Manoj is joining through phone.
Okay. ठीक है. Okay, we are starting the webinar now. So good evening, everybody, and welcome to this postgraduate lecture series as part of the MedEClasses initiative in which we try to cover the entirety of pediatric endocrinology over the 36 modules, covering different aspects. And we have been covering electrolytes for the last few months. We already covered hypo and hypernatremia as well as hypokalemia. So today we're going to finish off the electrolyte module using the module on hyperkalemia. Now, hyperkalemia is a scenario which is usually an acute emergency and we don't encounter in terms of chronic causes, but that can have huge implications in terms of evaluation and management. So Dr. Vibha, what are the scenarios in which you will be worried about hyperkalemia, and how would you like to give a key message as to beginning as to when should we suspect and how do we really react to it?
So like for the residents' point of view, generally we do a lot of transfusion in case of the hemolytic anemia and all. So hyperkalemia is commonly found in the scenarios of hemolysis. If we give the blood has been kept for so long and it causes cell hemolysis, then it will lead to the this hyperkalemia. And in conditions like we have extrarenal causes, like in the this congenital adrenal hyperplasia, we can have hyperkalemia. And if there is glomerulopathies, if there is tubular dysfunctions, then we can have hyperkalemia. So generally, when there is renal and extrarenal causes, that can lead to hyperkalemia, not just the excess intake or just excess IV fluids.
So unless your kidneys are defective, usually you will not develop hyperkalemia is one of the messages which are there and which will make a theme. So it's basically not because of increased intake. It is more in terms of decreased loss, which has happened. And of course, there is a third compartment, the intracellular compartment from which it can shift from there. So Dr. Manoj, in your perspective, what will be the key manifestations of hyperkalemia which we need to be aware of?
Yeah, thank you. Thank you, sir. So first of all, hyperkalemia don't have any symptoms. Basically, they present with the paralysis, or at the extreme stages, it present with the arrhythmias or arrest. So it is very vital to know the symptoms, and we have to manage according to that. So this is
the key message as against hyponatremia, hypernatremia, or hypokalemia, where there are a lot of manifestations there. The only manifestations of hyperkalemia may actually be a cardiac arrest or paralysis. So it may be too late. So you need to know when to worry and when to bother. So we'll be discussing all these issues along with a lot of practical discussions with regards to what are the relevant aspects, and we'll go forward. So we'll start off with this particular case. And this was an interesting case which presented to us. This is a case which provides you with dilemma also, because often we talk about just acute hyperkalemia, but in certain scenarios, you may have chronic causes as well. So we had this 1-month-old child who presented with reduced feeding, and this child had not gained weight at all in that perspective. And investigation showed hyponatremia and hyperkalemia. So usually we talk about sodium and potassium being linked. And when we discuss electrolyte, we said that whenever your sodium goes down, generally the potassium goes up. When your sodium goes up, the potassium goes down. So this is again going a situation where the sodium is low, potassium is high, suggesting that there is a problem in the renin, angiotensin, aldosterone system. Now, further workup, of course, the first thing you will consider in a child would be to exclude congenital adrenal hyperplasia or adrenal hypoplasia congenita, 17-hydroxyprogesterone and cortisol levels were both normal. Now, if we go further our algorithm, we found that PRA and aldosterone levels were high. So we had a child who had a high aldosterone, and despite that had hyponatremia and hyperkalemia, indicating that we are dealing with a aldosterone resistant state. So this led to the diagnosis of quote-unquote pseudo-hypoaldosteronism. But here comes a catch. So whenever you're making a diagnosis which is rare, you have to think of other possibilities. And we'll discuss subsequently that a pseudo-hypoaldosteronism-like state can be induced via infection and obstruction. So this actually happened to be a UTI in the setting of obstructive uropathy, which resulted in a transient aldosterone resistance, and that caused this scenario. So whenever you're diagnosing these scenarios, think about obstruction and infection, which becomes important in that regards. Now, this is the format which we'll follow. We'll start off a bit about pathophysiology of hyperkalemia. Then we'll move forward towards criteria and etiology with Dr. Vibha. We'll be discussing about, then I'll touch base about assessment and management. And finally, we'll have a quick, interesting scenarios and question answer sessions which Dr. Manoj will take forward. So all of you can participate in that using the chat option subsequently. We'll also be taking the questions at the end of it in that perspective. You all can go and have a look at our website, learning.brosociety.in, where there are a lot of resources with regards to pediatric endocrinology, besides a number of courses, and our e-learning portal in the YouTube channel, and the various courses which are available, including fellowship programs, diploma programs, and we have an exclusive course for postgraduates which covers all these modules over a 3-year period, specifically for pediatric postgraduates in that perspective. You can also follow our grand rounds, which are more in a pediatric endocrine perspective, symposiums which happen regularly, in this PG lecture series, which we plan over the next 3 years to complete the entirety of pediatric endocrinology. You can also have a look at our multiple publications, which are there also in the form of physical as well as virtual platforms, and a mobile application which guides evaluation. So before we go ahead about hyperkalemia, we need to primarily understand that there are 3 major organs which are regulating the potassium homeostasis. It's largely the intestine and the kidney, but remember, the most potassium in the body is inside the cell. So you can consider cellular compartment as also an important organ, or let's say a repository of potassium in that perspective. Now, if you have a problem in the intracellular compartment wherein your shift is there, so if you've got huge amount of money which is there in the bank, and suddenly the bank gives you all the money, your liquidity goes up, a same scenario will happen that your potassium will go up immediately in the circulation. Now, this is usually an acute phenomena. But remember, whenever you have a lot of load of potassium, if your kidneys are functioning properly, they will excrete the potassium in that perspective. So this will be an acute life-threatening condition like what Vibha talked about in the form of a hemolysis, which may happen in that scenario in a blood transfusion reaction that will cause hyperkalemia, but this will be transient in that perspective. Very importantly, to have a chronic hyperkalemia, you need to have a problem in the renal system. So either the glomeruli or the tubules, or you have a problem in the renin-angiotensin-aldosterone system, which is regulating all this process. All these will cause chronic hyperkalemia. So any condition in which you have a chronic hyperkalemia, you have a problem either in the kidneys or in the renin-aldosterone system. And this is something which will result in reduced potassium excretion, and you will have a chronic hyperkalemia. The concept again becomes important that anybody who is hyperkalemic should have an increased urinary potassium. If you have hyperkalemia with decreased urinary excretion, you are basically talking about a scenario in which there is a problem in the RAS axis. And this forms the basis of the use of urinary potassium to creatinine ratio and transtubular potassium gradient, the 2 things which I'll talk about when we talk about evaluation of hyperkalemia in the assessment of hyperkalemia. So individuals who have got a high serum potassium but less potassium in the urine, you're thinking of a renal cause in that perspective. Now, if we talk about intestinal, oral, or intravenous load, as Vibha talked about, if you get too much potassium, the kidneys are very efficient. They will basically wash it out. So this will basically be a self-limiting scenario, which is something which we won't be worried about in that perspective. So major chronic causes will be renal or adrenal. This is what we'll talk about in that perspective. Now, as large amount of potassium is in the cells, we need to understand about the cellular flux of potassium. We know that the potassium concentration in the cells is around 40 times more than the plasma, and around 99% of all potassium is inside the cell. And this is basically maintained, this gradient is maintained against a sodium gradient as well, which is pretty much similar, like 14 times, using a very, very important sodium potassium ATPase, which is the active transport system, which eats up a lot of ATP of the body, which allows this exchange of potassium inside and sodium on the outside. And this channel becomes very, very important. An important regulator of this channel, of course, is insulin. And if you have insulin deficiency states like diabetic ketoacidosis, your potassium will basically be coming out in that perspective, and you will have less total body potassium, but the potassium in the plasma may be more because of this insulin deficiency. And this we have discussed a lot in the setting of diabetic ketoacidosis. As soon as you give insulin, the potassium shifts inside the cell and you will have a severe hypokalemia in that perspective, and something this is important to understand. Now, remember, the proton and potassium have an antagonistic action. If you have systemic acidosis, the body will like to push this potassium inside the cell so that the blood doesn't have, the plasma doesn't have a severe acidosis. And in exchange of this proton, you will have an excess of potassium. So if you have metabolic acidosis, there will be a rise in serum potassium level. And this we'll be discussing in terms of assessment, that for every 0.1 decrease in pH, you have a rise of potassium of around 0.6. This again is very, very relevant in the setting of diabetic ketoacidosis. Once you correct insulin deficiency, once you correct acidosis, suddenly all the potassium will go into the cells and you will have severe hypokalemia. So for every 0.1 decline in potassium, 0.1 decline in pH, your potassium goes up by 0.6. This is very important. So if you have a pH of, let's say, 7, you have to subtract 2.4 from the actual measured amount of potassium from the extracellular fluid to get the exact amount of true potassium status. And this is what is important in that perspective. So if you have acidosis, you will also have hyperkalemia. Now, beta agonists also activate the sodium potassium ATPase channel, and they will help out in terms of treatment of hyperkalemia. They will push your potassium inside the cells, and that's what makes them effective in that perspective, in that regards. Now, as I've discussed, the major cause of chronic hyperkalemia is the lack of renal excretion. So we need to understand a bit about potassium handling by the kidneys. Now, most of the potassium which is coming to the blood is filtered, and around 100% of it is actually absorbed in the proximal tubule. So whatever potassium actually excreted is not the one which is filtered. So remember, all that you have filtered is absorbed here, and then the active egress of potassium, the active excretion of potassium actually happens at the level of collecting duct. And the driving force of this is the epithelial sodium chloride channel. Now, this epithelial sodium chloride channel causes the sodium to enter into the plasma, and along with that, you also have entry of chloride. Now, the chloride moves slowly as compared to sodium. So there is an electronegative environment within the lumen of the collecting duct. And if you have electronegative environment, it will basically drag all your positive ions, and that's how your potassium comes into this lumen, it is lost. So the entire excretion of potassium, which is actually happening from the kidneys, is happening because of this exchange of effectively the sodium with the potassium in the epithelial sodium chloride channel. Other positive ions like proton, like magnesium, like calcium may also be lost in exchange to this sodium entry. But it's largely the potassium and proton which are important. And we discuss a lot when we talk about RTA is that the ammonium production is the one which determines the excretion of proton. So now from this, what we understand is that if you have reduced delivery of sodium in the collecting duct, you will not have enough sodium entering out from there. So the potassium pump or excretion will become less. So if somebody is dehydrated, somebody is not having any sodium in diet, you don't have enough sodium to exchange for potassium, you will develop hyperkalemia in that perspective, in that regards. And that's something important to understand. Now, the major regulator of the epithelial sodium chloride channel is aldosterone, acting through its mineralocorticoid receptor. In a nutshell, the only effect of aldosterone is to push the mineralocorticoid receptor action, will push the epithelial sodium chloride channel from the cytoplasm to the membrane. So in a way, it is now making the membrane more permeable to sodium. Just like the major effect of vitamin D is to increase the capability of absorbing calcium, the major effect of aldosterone is increasing the availability of the epithelial sodium chloride channel, increasing the levels of expression, causing sodium intake. And of course, if you're taking in sodium, you will have to push potassium out. So defects in the ENF defect channel, mineralocorticoid receptor or aldosterone will all cause hyperkalemia. Now, aldosterone is largely regulated by the renin-angiotensin-aldosterone system, which in turn is regulated via potassium and volume. So if there is hyperkalemia, as discussed earlier, if you have increased load, if somebody is having a lot of potassium, the kidneys will start producing renin. If there is hypovolemia, again, your renin axis will get activated, and this renin will convert angiotensinogen to angiotensin 1, which will then be converted via the angiotensin convertase enzyme in the lungs to Ang2, which will cause production of aldosterone. So this or entire renin, angiotensin, aldosterone system will regulate the epithelial sodium chloride channel in that perspective. A very important thing to remember is that the major regulator of aldosterone secretion is renin and not ACTH. And that is why when we differentiate primary adrenal insufficiency from central adrenal insufficiency, there is a big difference in terms of potassium. Now, both of these conditions will have hyponatremia, but hyperkalemia will only happen in a primary adrenal problem because there the aldosterone production is defective. You will basically have no hyperkalemia if you have a central cause because their ACTH is affected, but renin and this whole system, renin-angiotensin system is working. So central adrenal insufficiency because of a hypothalamic or a pituitary cause or ACTH deficiency or a ACTH resistant state like familial glucocorticoid deficiency will not have hyperkalemia. They will predominantly have hyponatremia. On the other hand, if you have isolated aldosterone problem, aldosterone deficiency or aldosterone resistance, you will have more of hyperkalemia. Your hyponatremia will be less. Now, what is the reason for that? The reason for that is that cortisol inhibits AVP production. Cortisol is also required for excretion of free water. So in conditions where you have a combined cortisol and an aldosterone defect, like adrenocortical insufficiency, you will have increased AVP, which will cause free water retention, causing hyponatremia. So hyponatremia will be maximum if you have both glucocorticoid and mineralocorticoid deficiency. Potassium will also be high. If you have isolated glucocorticoid deficiency, you will just have hyponatremia. Potassium will be normal. If you have a mineralocorticoid problem, mineralocorticoid deficiency or resistance, the major problem will be hyperkalemia, mildish hyponatremia. So because they will present late, your potassium may go up to 8, 9, or 10. So that's an important concept to remember. Now, of course, if there is a problem in the kidneys, if there is a problem in renin, angiotensin convertase enzyme, and a lot of these drugs, the ACE inhibitors, the ARB, they will all act on this direct effect. Primary adrenocortical defect, aldosterone synthesis problem, a mineralocorticoid receptor problem, or an epithelial sodium chloride channel, all will cause decreased potassium excretion and will result in hyperkalemia. Now, if you're losing more potassium, remember, proton and potassium are competing with each other. So if you have hyperkalemia, body will not be, if you're losing, your potassium loss is less, the proton will obviously compete in that perspective. So that will also impair your production of the acid excretion as well. And that way it will cause a metabolic acidosis, which is mild. So anybody who has hyperkalemia will have mild metabolic acidosis. And opposite, if you have metabolic acidosis, you will have hyperkalemia. So potassium and proton basically go up together. And this is the mechanism of what we call quote unquote type 4 RTA, in which you have hyperkalemia, which causes a bit of metabolic acidosis in that perspective. So remember, proton and potassium are linked in that regard. So to summarize the pathophysiology, the problem could be extracellular shift, which is an acute problem like metabolic acidosis, tissue lysis, insulin deficiency. If you are able to manage acutely and if your kidneys are fine, there will be no problems. Increased intake will not cause hyperkalemia. If you give too much IV potassium, that may, in somebody who has an immature kidneys like preterms, or if there is a renal insufficiency, potassium salts, but this will be very, very unlikely. Predominantly, what we are talking about is reduced renal loss because of a primary glomerular problem, effective hypovolemia where sodium delivery is less, and therefore you can't exchange the sodium to potassium. A renin-angiotensin-aldosterone system defect, which we discuss in detail, lots of drugs, ACE inhibitors, angiotensin receptor blockers, spironolactone, they will cause that. So just to summarize, hyperkalemia can be because of increased intake, oral and intravenous. Remember, this will be self-limiting if your kidneys are working fine. Only if you have renal dysfunction, the problem will become more. It may be because of a cellular shift, because of acidosis, channelopathies, or cell lysis. Again, you will have a sudden rise, and if your kidneys are fine, it will be not sustained. It can be because of a reduced renal loss, which may be a renal problem like glomerular or a tubular disorder associated with hemodilution, fluid overload, reduction in uric acid, and decrease in hemoglobin, or RAS defect, which is characterized basically by dehydration and hemoconcentration. So this is the basic template which we'll work about, and then we'll go forward in terms of evaluation and management. So I'll now hand it over to Dr. Vibha to go ahead with regards to the other aspects of further discussion in terms of etiology. So Dr. Vibha, over to you.
Is my screen visible?
Yes, please go ahead.
Okay, sir. So thank you so much, sir. As sir has beautifully described about the pathophysiology of hyperkalemia, so my job has become pretty simple. I have just to enumerate the causes of hyperkalemia. So here we go. First, let's see what happened when we take excess of oral or IV potassium. So what we expect when there is an excess of oral or potassium so we expect the RAS axis to get activated. And what does RAS do? It increases the renin, and renin will increase the aldosterone. And this aldosterone will simultaneously decrease the excess potassium. It will secrete the excess potassium in the urine. So until then, it is a very self-limiting condition. So whenever there is a potassium overload, all the excess potassium is excreted in the urine unless there is a renal dysfunction or there is an immature tubules like in the infants, or the patient is on potassium sparing diuretics like amiloride and the spironolactone. So now coming to the metabolic acidosis, as sir has already described, like the cells are in a buffer state. It likes to maintain the electrical neutrality in the body. So what happens when we have lots of protons outside the cell in metabolic acidosis? What happens? They go inside the cells, and in exchange of these protons, the potassiums are pushed outside the cell, and this excess of potassium will cause hyperkalemia. So, and the similar mechanism happens in the kidney also. The excess of protons excreted in the urine, and the potassium is absorbed. So this causes, as sir is described, whenever we have hyperkalemia, there will be metabolic acidosis, and if there is a metabolic acidosis, there will be hyperkalemia. So both goes hand in hand. So if there is a decline in 0.1 pH, the potassium will rise by 0.6, and this is is for only metabolic acidosis, not for the respiratory acidosis. So coming to the channelopathies, what happens in the channelopathies? Hypokalemic channelopathies is very common, but the hyperkalemic channelopathies is rare, and it occurs due to the defect in the sodium channel. What happens here? Due to the defect in the sodium channel, the potassium rises very significantly. There is a transient and the severe rise in the potassium, and this causes ascending paralysis, just like in the Guillain-Barré syndrome. So we should always look for the potassium levels if there is a patient who is having ascending paralysis. This is the message from this slide. So what happens in the cell lysis? Why does cell lysis causes hyperkalemia? Let's see. As we all know, potassium, phosphate, and magnesium, they all are intracellular ions. So in the conditions of cell lysis, like in the tumor lysis syndrome, in the rhabdomyolysis, in the hemolysis, when the cell lysed, all these intracellular ions are released in the circulation, and that causes hyperkalemia, hypophosphatemia, and hypermagnesemia. This increased phosphate binds with the calcium, and this decreases the ionic calcium. So the conditions of cell lysis presents with high phosphate and low calcium. So this always calcium, magnesium, phosphate, and potassium should be ordered if we are giving a blood transfusion, or there is a patient who is on chemo, or there is a patient who is in decay, or and there is a chances of rhabdomyolysis. So keep in mind, if one of the intracellular ion is lost in the circulation, we should measure for the another ion. So what happens in the renal dysfunction? As sir has already discussed, hyperkalemia will always happen if the renal function is impaired, if the renals are not able to excrete the excess of potassium into the urine. So the mild and the moderate chronic kidney diseases will not cause hyperkalemia until the GFR becomes less than 30. The last stages kidney diseases will cause renal this hyperkalemia, because at this stage the kidney is not able to excrete the potassium. In the tubular conditions like type 4 RTA, RAS defect, obstructive uropathy, and the sickle cell anemia, these conditions will also cause hyperkalemia, because in these conditions also the kidney is not able to secrete the excess of potassium. Now, the conditions like cardiac failure, liver diseases, and the chronic liver diseases, what they cause, they reduce the effective fluid volume. So what happens there? If the volume which is coming to the kidney is reduced, the effective GFR is reduced. So what happened? The sodium delivered is the sodium which is being delivered to the collecting tubule is actually low. So in exchange to this low sodium, the potassium and proton will also be secreted low. So this is a way, as sir has already discussed, whenever there is a low delivery of sodium in the collecting tubule, the potassium and the proton that has to be secreted in the collecting tubule will also be low, and this will cause the hyperkalemia in the conditions of reduced effective volume. So we should, how should we manage these conditions? We should manage by giving diuretics, and we should keep in mind that the blood pressure of the patient is in the normal limit. So now coming to the RAS defect. As we all know, the potassium is regulated and controlled by the RAS axis, and RAS when the RAS axis is activated, renin increases, aldosterone increases, and it decreases the potassium. So when there is defect in the RAS system, it could be anywhere: ENaC channel, mineralocorticoid receptor. It will present like dehydration, hypotension, hyperkalemic metabolic acidosis, And low renin, adrenal insufficiency, low aldosterone, pH, all these conditions will present with hyperkalemia. I will discuss all these conditions later on. So any problem in the RAS defect, if the RAS axis is not activated, it will cause hyperkalemia. So coming to the adrenal insufficiency first, as sir has already mentioned that potassium is regulated by the renin system. And in the central and the receptor defect, there is no problem in the renin axis. So the potassium is absolutely normal in these two conditions of adrenal insufficiency, whether in the primary adrenal insufficiency, both mineralocorticoid, this glucocorticoid and androgen action, everything is disturbed. So these patients presented with pigmentation and hyperkalemia. This potassium level alone is a very big help in differentiating the central at the receptor problem and the primary adrenal insufficiency. So coming to the causes of CH that causes salt wasting. Salt wasting is what? Hyponatremia, hyperkalemia, and metabolic acidosis. So if any patient is having XY DSD, DSD is disorders of sexual development, and the adrenals are absolutely normal. So it could be SLO. SLO is Smith-Lamely Optis syndrome. Here we get syndromic facies like upturned nails, syndactyly, and how could we diagnose this? The 7-DHC level will be low here. In the condition where there is a salt wasting, there is a XY-DSD, but there is a hyperplasia in the adrenals. So we can suspect of STAR and SCC. SCC is side chain cleavage. All the metabolites, sodium, potassium, androgens, everything will be low here. XX-DSD, it's the most common one. Everybody knows here. Here the 17 OHP levels will be high. In the 3-beta HSD and the POR defect, it could present with both XXDSD and XYDSD. And here also we'll get adrenal hyperplasia. In the POR, we'll get a borderline elevated 17 OHP. So now coming to the Sip11B2 defect. So what it is? Basically, the Sip11B2 gene regulates the Sip11A aldosterone synthase, which as you can see here, the last enzyme which is required for the conversion of corticosterone to aldosterone. So when there is a defect in the Sip11B2, it causes the isolated mineralocorticoid deficiency. There will be normal cortisol, normal androgen, and the patient will present with just failure to thrive, polyuria, hyperkalemia, and metabolic acidosis. So now coming to the very interesting phenomenon of pseudohypoaldosteronism. What happens here actually? There is a problem in the, there could be a problem in the ENaC channel, which is the sodium epithelial channel, or in the mineralocorticoid receptor channel. As sir has already described that the mineralocorticoid receptor is required to push the ENaC channel to the membrane. So if there is a problem in the ENaC channel, it will cause the PHA1, which is autosomal recessive, and it is a severe condition because it involves kidney along with other systems like cutaneous, respiratory, and the GI also. And it presents with respiratory recurrent infections, rashes, blockage of the sweat glands, and loose motions. And this condition is very close differential of cystic fibrosis due to recurrent respiratory infection and increased sodium in the sweat. Now coming to the PHA1, which is a defect in the mineralocorticoid receptor. It is an autosomal dominant. It is localized to kidney only. It resolves and it is reversible. It can be treated. There is another type of PHA, which could be due to obstruction and urinary tract infection. This is the case. This was discussed by Sir in the beginning. It causes when there is a this obstructive uropathy or infection. It causes resistance to the aldosterone in the kidney, which causes hyperkalemia, and it is transient. So, if I want to conclude all these three, there is a table. If there is a defect in iliac channel, it will present with recurrent respiratory infections along with loose motions, rashes, and it is a persistent condition. Patient will come to you again and again, will get admitted. And if there is a defect in the mineralocorticoid receptor, it is a moderate condition. Only the renal manifestations will be there and it will be resolved. And if there is a urinary tract infection and the obstructive uropathy, it will only involve, and it is a transient condition. So if a patient is having like hyperkalemia, acidosis, and aldosterone is high, PRA is high, so always do urine RM and USG KUB to rule out this UTI and obstructive uropathy, because this simple investigation will save us from putting a lot of investigation doing other like CT and all. So keep in mind, just urine RM and the USG KUB will be so much helpful in ruling out these diseases. Now coming to the next one, the drugs that will cause sodium epithelial channel inhibition, and that is amyloid, trimethoprim, and the pentamidine. As these drugs will inhibit iliac channel and it will cause hyperkalemia. And the drugs that will block mineralocorticoid receptor is as this spironolactone and the eplerenone. So these drugs alone will not cause severe hyperkalemia, but when there is associated renal dysfunction, these will cause severe hyperkalemia. So when we are ordering these drugs, when we are prescribing these drugs, we should take a detailed history. We should take a history of if there is any history that will cause reduced this effective volume, like cardiac diseases, liver diseases, and nephrotic syndrome, and this. Am I missing something? Okay. So by taking a good history, we can prevent hyperkalemia if we are prescribing these drugs. So now the drugs that will affect RAS axis, beta blockers like propranolol, this inhibit the sympathetic activity and it is a very minor impact on the potassium levels. NSAIDs decrease the renin activity and renal function, and they worsen the hyperkalemia with renal failure. What does heparin do? Heparin damages the this aldosterone producing cells and increases the potassium with 0.5 to 1 millimole. ACE inhibitors, ARBCs also reduce aldosterone production, and spironolactone, amyloid, as these drugs has previously been discussed. So these are the drugs that will cause hyperkalemia, someone alone or someone along with the renal dysfunction. So keep your eyes and ear open when you are prescribing these drugs in a patient with renal dysfunction. So Gordon syndrome. What actually is Gordon syndrome? In Gordon syndrome, there is a defect in the WNK14. It controls the sodium chloride importer channel. This is the same channel which causes the Gentleman syndrome. This is the same channel where the thiazide works. So what happens when this is activated? It causes more absorption of the sodium. So along with the sodium, more water is absorbed, which causes hypertension, and the renin is decreased. When the renin is decreased, the potassium already increases. So it causes hyperkalemia. So Gordon syndrome is a condition which causes hypernatremia, hyperkalemia with metabolic acidosis and hypertension. This is just opposite to the Gentleman syndrome. So if we conclude all the causes, we can just summarize like in the renal causes and the extrarenal. Extrarenals are the just adrenals and the renals, renal dysfunction, glomerular and the tubular, and the excessive intake via oral and the IV. And this is all for. Thank you.
Thank you, Dr. Vibha. So, for very nicely summarizing the entirety of these aspects of etiology and making my life much easier with regards to further approach to evaluation in that perspective. So, Vibha has really covered about the etiology very, very clearly and remarkably. And what we can see is that out of the various causes that we are seeing hyperkalemia, we can have problems in terms of intake, in terms of cellular shift, but largely we are talking about renal versus adrenal. That's the basic theme. So the key questions that a physician who is managing a person who has got hyperkalemia in terms of evaluation are three. They are basically very, very clear. Is it really hyperkalemia? If it's hyperkalemia, what is the site of hyperkalemia? And finally, what's the cause? So in that perspective, of course, the most common features as we discussed with hyperkalemia, they don't have any clinical feature. They are usually ECG changes. So if you've got classical ECG changes, if there is cardiac arrhythmia, particularly in the form of heart blocks, and if there is a sudden onset ascending paralysis, syncope, or weakness, but usually the hyperkalemia is a very, very severe condition. So we need to preempt and get an ECG done before all these changes happen in that perspective. Now, the levels really have effect on manifestations. So the muscular changes typically start from around 6.5 when you will have paralysis. The cardiac changes start to have a peak tented T waves by around 5.5 to 6. As they progress from 6.5, we have the widening of QRS complex. You will have ectopic beats. And finally, you will have loss of P wave and sine wave pattern will happen. That will happen very late in that perspective. So we are looking at peak T waves as an early manifestation of hyperkalemia. And that's what we want to evaluate. Now, importantly, the potassium levels are different at different ages. So we have to look for age-specific criteria, particularly preterm neonates and term neonates will have a higher potassium level. So we can tolerate levels up to 6.5 in preterms and 5.9 in term neonates. Infants, the level come down, and childhood typically level, which is above 5, we start worrying. Remember that blood gas analyzers will tend to give a lower value by 0.4. So this is something which we need to be correcting for when you're assessing in that regards. Since potassium is an intracellular ion, if there is a pressure, squeeze sample or a tourniquet, or if you have a very much increase in cell counts like thrombocytosis, you have got leukemia, or there is a polycythemia, those sort of scenarios will also cause a falsely high potassium in that perspective. Now, once we know that this is hyperkalemia, we want to then know whether it's largely renal or adrenal, and that becomes important. So look at urine output. Of course, if there is polyuria, you're looking at basically scenarios where they're losing sodium, but you're not losing potassium. That's like a RAS defect. Oliguria will favor renal failure. Tissue lysis, the history will be clear, like chemotherapy for ALL, hemolysis. And in DK, if you have a sudden onset pain in a particular area, there is a rhabdomyolysis which is happening. Look at the fluid status. In somebody who has got a RAS defect, you will have hypovolemia, while if there is an issue in terms of the fluid overload, effective hypovolemia, you may actually have more fluid. Ask always for the history of a potassium-sparing diuretic like amiloride, like aldactone, and also ACE inhibitors and ARB. Look for pigmentation to point towards primary adrenal insufficiency. Look for the genitalia to identify DSD, which could be XX and XY, which we'll discuss later on as well. Now, major workup, of course, is to exclude a renal failure. So look at urea and creatinine. And remember that if you have a RAS defect, there will be hypovolemia. You will have a high urea, and that may cause a bit of a confusion in that perspective. Urinary potassium is very important. Anybody who has hyperkalemia should have a high urinary potassium. But if your urinary potassium is low, this means it's a RAS defect, while if it's more than 100, it's typically a potassium load. There is another important investigation to look at is the urinary potassium to creatinine ratio, which basically corrects for the renal dysfunction. If it's less than 15 milliequivalents per gram, that is an indicator of inadequate potassium excretion. And in fact, this urinary potassium to creatinine ratio is emerging as a better indicator of the renal potassium handling as compared to the traditional TTKG or the transtubular potassium gradient, which I'll talk a bit later subsequently. Now, serum sodium is also important. As we discussed, sodium and potassium are usually opposing. So we expect that you will have hyponatremia in most cases. But remember, there is only one condition in which you have high sodium and high potassium. That's Gordon syndrome. That's a giveaway diagnosis in that perspective. Now, what's really is the transtubular potassium gradient? The simple thing to remember is that the major factor which is regulating the push of potassium into the lumen is the renin-angiotensin-aldosterone system. So we are trying to see what is the gradient of potassium in the blood as well as the tubule. So what it basically looks at is that you look at the potassium excretion in the form of urinary potassium and the plasma potassium, and you have to correct it for something. So you correct it for the osmolality. So as compared to other osmoles which are being excreted, are we excreting the same amount of potassium in the urine or not? So it's the ratio of urinary to plasma potassium divided by urinary osmolality upon plasma osmolality. So whether the potassium excretion is appropriate for other osmolar excretion, and this is potassium excretion, a major factor is the RAS defect, we can understand from there. However, there are a lot of lacunae in this test. You need to have a urinary osmolality which is reasonably high. So dilute urine will cause a confusion, and your urinary sodium should be reasonable. So only then you would be able to assess in that perspective. And if your TTKG is less with hyperkalemia, that is, you have got a high serum potassium, but less in terms of urinary potassium, this is a RAS defect in that perspective. Now, we have now known the site, renal or adrenal. We'll now go forward to the cause of hyperkalemia. So RAS defect, as typically already Vibha has discussed wonderfully, we have to look at a few things. Renin, of course, will be high in everybody, except if you have a primary renin problem, which does not usually happen in children. It usually happens in older individuals, people who have type 2 diabetes, in which the renal dysfunction is happening, and that's why the renin is going down, or you have a diabetic nephropathy, which is happening. If the aldosterone is low, we are talking with a hypoaldosteronism or maybe a CH variant. And finally, you will look at various parameters which will give you the clue. The most important, of course, is 17-hydroxyprogesterone and DHEAs, which will classify CH, particularly in infantile age group. And whenever you have a high aldosterone, high renin, get an imaging, get a urine routine microscopy to identify the transient form of pseudohypoaldosteronism. So the approach to hyperkalemia is that you look for any acute causes like renal failure, drugs, or tissue lysis. Then if all of them are not there, go for renin. If renin is low, this is hyporenism. Less likely in the pediatric, especially the neonatal population. Mostly you will have a high renin. And with that, if your aldosterone is low, it may either be an adrenocortical insufficiency or it may be an isolated adrenal aldosterone defect. So if your cortisol is low, it's a combined defect, a primary adrenal insufficiency. If cortisol is normal, you're thinking of an aldosterone synthesis problem. On the other hand, if you have a high aldosterone and a high renin, you're dealing with a pseudo-hypoaldosteronism. So here maybe you will look at whether it's a transient or a permanent cause. So the major investigation should be only done because often you will know the cause very clearly. You may have a renal failure, drugs are there, you know that there's tissue lysis, so 95% cases will go there. But if you have a chronic hyperkalemia, then you go ahead with these investigations and work up in that regards. Now, the most important age group in which hyperkalemia may present with a chronic one is actually the neonatal age group. And here, if you look at the genitalia and the size of adrenals, you will get the clue in that regards. So if you have an individual who has got a XX DSD with enlarged adrenals, this is usually 21-hydroxylase deficiency. If you have XX or XY, this could be 3-beta and POR. And if you have a XY DSD with a large adrenals, you're dealing with a star defect. On the other hand, if you have a normal male who has got small adrenals. This is X-linked adrenal hypoplasia congenita. While if everything is normal, think of a pseudo-hypoaldosteronism and your aldosterone levels will be high. So always look at the neonate, look at the genitalia, get an ultrasound with adrenal size. 90% of cases, you will get the diagnosis where you are heading in that perspective. So for the neonate with salt wasting, hyponatremia, hyperkalemia, exclude infection and obstruction. Look at genitalia. If it's atypical and you have got no palpable gonad, this is XX-DSD, 95% will be CAH, 21-hydroxylase deficiency. Get a 17-OHP done. If it's high, this is 21-hydroxylase deficiency. If it's borderline, it could be 3-beta or 11-hydroxylase. If you have a palpable gonad, this is XY-DSD with salt wasting. Less common, look at DHEAS. If DHEAS is low, you're dealing with a proximal defect. If DHEAS is high, you're dealing with 3-beta HSD. So again, look at genitalia and gonad, you will know how to classify. If the genitalia is normal and you have a male child, you can still have CAH 21. So get a 17-OHP. If 17-OHP is normal, you can still have adrenal hypoplasia congenita. Get an imaging done. If it's small, it is AHC. And if it is normal, then we'll go more in terms of pseudo-hypoaldosteronism. In a normal female, your 17-OHP may be low in star. If 17-OHP is normal, then you go ahead with evaluation for the rarer forms of hyperaldosteronism. And in that, you look at aldosterone. If it's low, it is synthesis defect. If this is high, it is pseudo-hypoaldosteronism. The crux is to look at genitalia. Then, depending upon the genitalia and the gender, you can then decide about workup for AHC and 21-hydroxylase in a normal male, and then only go ahead with the rarer forms of pseudo-hypoaldosteronism in that perspective. So we'll go through a few cases. 5-year-old child with syncope had hyperkalemia, was given anti-malarial. So what we're looking at is an acute form of hyperkalemia here. And there was red urine. So there is clearly a hemolysis which is happening. So what are we looking at in a child who has received anti-malarial who develops hemolysis? So the options you can mention on the chat. So this is clearly a scenario of tissue lysis because of G6PD deficiency in that scenario. 3-week-old child, failure to thrive with hyponatremia and hyperkalemia, not gaining weight in this time, dehydrated, which means it's more like adrenocortical rather than renal cause. Urinary sodium is high. There is atypical genitalia. So this is clearly, if we talk about that algorithm of neonate with salt wasting, atypical genitalia, no gonads, XX-DSD, 95-99%, 21-hydroxylase deficiency. So what you need to do is to do a 17-hydroxyprogesterone, very high. So this is 21-hydroxylase deficiency classically in that perspective. 3-month-old child with failure to thrive, again not gaining weight. There is hyponatremia and hyperkalemia. There is no pigmentation, genitalia normal. So adrenal causes become a bit less likely. We do a further evaluation. We find that PRA is high. Aldosterone is also on the higher side. This is pseudo-hypoaldosteronism, which is the more severe form, the recessive form. You will also have respiratory manifestations which may happen in that regards. 1-month-old child with reduced feeding, again not gaining weight. Sodium is low, potassium is high. 17-hydroxyprogesterone and cortisol are appropriate. So there is no adrenocortical insufficiency, and this is the first case we talked about. There is also a high renin and a high aldosterone. So this looks like a aldosterone resistance. But what will you do next in this scenario? You can write on the chat box. You have a neonate who has got salt wasting, who has got hyponatremia and hyperkalemia with a normal cortisol and 17-OHP and high renin and aldosterone. The diagnosis is pseudo-hypoaldosteronism. What should you do next? I think the most important part, which I've emphasized a lot, is don't rush to the diagnosis of PHA. Look at urine, look at ultrasound, and get the diagnosis. And that's very, very important from that perspective. So there was UTI, there was obstruction. Once you treat that, this child will be fine from that perspective and regards. 1-year-old child with failure to thrive, irritability, higher level of blood pressure, sodium is also high, potassium is also high. So this is an unusual scenario of hypernatremia with hyperkalemia. Only one differential which we have discussed renin and aldosterone are on the lower side. This is classically a problem in the sodium chloride symporter. This is opposite of Gentleman syndrome. This is Gordon syndrome, which we discussed. Finally, coming on to management. So this is more like an acute management that we are going to talk about. The goal of management is primarily to protect the heart, because that's what the major problem happens in hyperkalemia. We need to have an immediate reduction followed by a sustained reduction from a long-term perspective. But first, protect the heart. Now, if you have clinical symptoms like paralysis, syncope, if there are ECG changes, that's urgency. And if you know that this potassium is going to increase, you need to be more bothered in terms of treatment. You have to very carefully do a continuous ECG monitoring, because a lot of problems can happen in that regards. Follow up on potassium levels as well. So the strategies you can do is to protect the heart from this potassium using calcium, which stabilizes the membrane. You can push the potassium into the cells using insulin and dextro drip or a beta agonist, or use a soda bicarb to produce the same picture of alkalosis, or you can increase the gastric excretion of potassium using either via the kidneys from furosemide or exchange raising like K-exilate, which will cause exchange of potassium in that perspective. And finally, you can use dialysis as an exchange mechanism. Now, you should go for an emergent treatment if there is paralysis or arrhythmia, which are acute symptoms, or the potassium is more than 7. So we have a higher cutoff in that perspective. But if there is a risk like tissue lysis, if your potassium is 6 to 7, you may also go for acute treatment in that regards. Now, rapid correction, very importantly, should be given in acute cases, treat the underlying cause, and most importantly, especially in individuals who are on all these medications, potassium supplements, ACE inhibitors, ARBs, potassium-sparing diuretics, they all should, of course, be stopped in that perspective. Now, calcium gluconate, you give 0.5 ml per kg up to 20 ml over 5 minutes as a slow infusion. If there is a cardiac arrest, now this is important, if there's cardiac arrest, calcium chloride may be more preferable in that scenario, and this has to be given using central line. You can repeat it if the ECG changes are persisting after 10 minutes. So you may repeat it just for prevention and protection of heart. You can use insulin dextrose to shift the potassium inside. So give 0.1 unit per kg, and for every 0.1 unit per kg, 500 milligram per kg is required. 10% dextrose should be used till 5 years, and later you can use 25% because volume can become an issue in certain scenarios. In severe cases, you can double the amount of the insulin dextrose that you're giving. Beta agonists like salbutamol in neonates 0.4 milligrams, infant 2.5 milligram will push the potassium inside the cell. Up to 10 years, you go up to 5 and then 10 milligrams. So this is one strategy which can help out immediately, even if you don't have an IV excess. Soda bicarbonate, again, 1 millimoles per kg over 10 to 15 minutes will push your potassium inside the cells. And very importantly, do not give soda bicarbonate and calcium gluconate together. They will precipitate and cause problems in that regards. Now, all these strategies are pretty much either protecting the heart or they are trying to shift it into the cells. You also need to remove it. So you can use exchange resins like sodium polystyrene sulfate, which can be given oral or rectal. Both modes will work, and repeat 4 to 6 hourly. Very importantly, neonates, you may have a problem because of obstruction and necrotizing enterocolitis. Furosemide will cause increased excretion in the urine. So 1 milligram per kg 6 hourly is affected. Somebody who has a renal disease will have resistance. You will need a higher dose. But if there is dehydration, avoid, you will cause more dehydration. Dialysis, finally, is the final mode, and hemodialysis is better than peritoneal dialysis for potassium excretion. If there is renal failure with potassium more than 6.5, go for dialysis in that regards. So to summarize the management, if there is paralysis or arrhythmia, you give calcium gluconate, insulin dextrose, soda bicarb, everything. Soda bicarb, beta agonist, dialysis, and resin. If, however, you do not have these symptoms and the potassium level is less than 7, you may consider in that perspective more than 7, or if 6 to 7 and there is a risk of rise, you treat. Otherwise, you go ahead with a chronic management in that perspective. Treat the cause, stop ACE inhibitor, then ARB. So the management is largely symptoms, any potassium levels. Without symptoms, level more than 7 or 6 to 7 with a risk of rise like lysis or renal failure in that perspective. That's what the primary aspect as far as the management is concerned. So I think what we'll do now is that we have discussed a lot with regards to different aspects of evaluation, assessment, and management. Dr. Manoj, I hope you are ready with the quiz, and we can go forward with the OSCE. And all of you can use the chat option to give the answers, and we will be discussing them. So and we'll also announce who has picked up the quickest in that perspective. So Dr. Manoj, you can share the screen.
As my screen is visible, sir?
No, not yet. Yeah, now we can see your screen, so you can start the presentation from there. So in the interim, while we load that, the key aspects are that hyperkalemia is a rare phenomena, but very important from an acute perspective. We need to be cautious in which person can develop hyperkalemia, and then we can go forward in terms of immediate management from that regards and assessment. So key aspect of assessment again are to look at the sodium level, look at the various forms of aldosterone problems and other regards as well. So
can you share it from your side, sir?
Yeah, I'll share from my side then. Okay. So we'll start with the OSCE then. So this is more in terms of a case format. So you can start with that.
So thank you, sir. It was a very nice and excellent discussion by Dr. Anurag sir and Dr. Vibha Yadav. So now we will move towards the very interesting questions that are basically designed for OSCE question. And these are the cases that we generally faces in our OPD. So these questions we have included. So without wasting of time, we have to move towards the questions answer. So my first case is a 13-year boy who presented with the diabetic ketoacidosis. Patient has a pH 6.9, which is a severe acidosis. Serum sodium is 128 millimole per liter, and potassium is 3 millimole per liter. So now, this child have severe diabetic ketoacidosis. So my first question is, what are the usual sodium common electrolyte abnormality that we generally see in the DK? So this answer you can write into the chat box.
So what do you expect in terms of sodium, whether you have a true sodium deficit, and along with that, whether you assess it normally or exaggerate that, and then what happens to potassium, whether you have hypo or hyperkalemia. So I think these are the key things to look at from that perspective. Yeah.
So, yeah.
So yeah, carry on. Yeah.
Yeah. So there are the hyponatremia and hypokalemia is common abnormality that we generally see in the DK. Hyponatremia is due to the dilutional hyponatremia, and we see the generally false picture of the potassium. Actually, due to the cellular shift or insulin deficiency and due to the acidosis, potassium come from the cell. So actually, potassium is low in the blood. But because of the cellular shift, we are seeing whatever potassium we are seeing, it is actually falsely elevated. So on the potassium perspective, there is the hypokalemia that it occurs due to the cellular shift. So, and my second question
is, got the hyponatremia, which you are exaggerated because of the sodium dilution, and then you have got hypokalemia, which is masked by potassium shift. Now the next question, Dr. Manoj.
Yeah. The second question is, what is the actual potassium in this case?
So you can write on the chat box.
Yeah. As we have discussed that we are seeing falsely elevated potassium into the blood. So what would be the actual potassium in this case?
So what is the potassium? Has anybody written on the chat box? Not yet. So we can continue. So we know that for every 0.1, how much does it increase, Dr. Manoj?
So every 0.1 decrease in the pH increase 0.6 millimole per liter cellular shift of the potassium. So that means in this case, pH is 6.9. So normal pH is 7.4. So there is a deficit of 0.5 of pH. So if we multiply with the 0.6, then the potassium loss from the body is 3 millimole per liter. So in the HUL blood, in HUL, total potassium will be nil in this patient.
So if you have hypokalemia with this severity of acidosis, I'll be very, very careful in that regards. Even starting with the fluid, I have to give potassium, and also importantly, never start insulin in this scenario unless the potassium is built up. So this is a severe scenario in that regards. So I think this question again, Dr. Manoj.
Yeah. So my third question is, what causes falsely elevated potassium in the diabetic ketoacidosis? So as we previously discussed,
yeah. Carry on.
Yeah. So as we previously discussed, there is an insulin deficiency in the diabetic ketoacidosis, which moves potassium from cell to the blood. And secondary thing, acidosis also drags the potassium from the cell. So these two mechanisms cause falsely elevated potassium in the diabetic ketoacidosis.
So basically, insulin deficiency and alkaloacidosis is causing the problem. So what other mechanism can cause false elevation, Dr. Manoj?
Yeah. So the other mechanism, as we discussed previously, that other mechanism is like acidosis. If we are giving some beta blockers, or due to the tumor lysis or tumor lysis or cell lysis or thrombocytopenia, thrombocytosis like picture, can cause falsely elevation of the potassium in the blood. It is mainly due to the cellular shift. So these are the mechanisms that cause falsely elevation of potassium.
Sure. So we'll move forward to the next case.
So the next case is 4-year-old boy presented with the red urine with increased CPK in the blood and diagnosed with the rhabdomyolysis with the potassium of 6.2 millimole per liter. So basically, this patient has the rhabdomyolysis, and due to this reason, potassium there is the hyperkalemia, which is the 6.2. So now my first question is, what will be the incorrect associated biochemical picture for this case scenario? First option is hyperphosphatemia. Second is hypermagnesemia. Third is hyperkalemia. Fourth is hypocalcemia. So among the four, which one is incorrect?
So I think this is an interesting question, and Vibha had discussed it a lot as well. So you can put on the Q&A or the chat, where Q&A if you can answer, or the chat you can answer the questions. I'll encourage all of you to write. So whether you will have hyperphosphatemia, hypermagnesemia, hypercalcemia, and hypocalcemia. Now, this question is such that only C or D can be correct, because you can either have hyper or hypocalcemia. So Manoj, you can go ahead.
Yeah, so basically, in the case of the tumor lysis, we generally see hyperphosphatemia, hypermagnesemia, and hyperkalemia. These pictures are associated because of the cell lysis. There is a movement of the intracellular ion into the blood, but we generally don't find hypercalcemia, because this phosphate bind with the calcium and it decrease the calcium level. So with the tumor lysis, there is the picture of the hypocalcemia, not a hypercalcemia.
So this has been answered correctly by Dr. Muthu, who said hypercalcemia.
Yeah.
What are the symptoms of hypercalcemia? I think Dr. Manoj, we have already discussed this, so you can just quickly go through.
Yeah. So what are the symptoms of the hyperkalemia? So basically, hyperkalemia don't present with any acute system. If the
So I think there seems to be a bit of an issue. So hyperkalemia generally is not really associated with symptoms. Often you will have symptoms which are very late, like paralysis, or you have got ascending paralysis and cardiac abnormalities. It's mainly the ECG changes that we are looking at in terms of the symptoms which are there. So we will move forward to the next scenario. So now the next question is, at what level of hyperkalemia do we get the ECG changes? So I think this we have discussed, that if your levels are typically going beyond 5.5, you will start having a problem in terms of the issues which are there with regards to the peak T waves which are happening. If it goes beyond 6.5, you have got the QRS complex which starts to widen. Sine wave will happen on 6.5 to 7, which we have discussed earlier in that regards. So if we just summarize, and this is what is again we discussed earlier, that depending upon the levels, you will have the peak T wave. 6, you will have widening of PR interval and QRS duration. and then you will have a sinusoidal wave around 8, which will be a very, very terminal thing. Remember, the key figures are anything above 7, you have to treat. 6 to 7 with rate of rise that you're expecting, you will need to treat again in that perspective. Now, next question is 1-month-old girl presented with dehydration, hyponatremia, and hyperkalemia. On examination, there is normal genitalia and no pigmentation. So you have a girl who has a normal genitalia, 17 OHP is normal, and aldosterone is high. So you can quickly think about what we had discussed earlier with regards to neonatal salt wasting. What is the most likely diagnosis? So maybe we can have quick answers on the Q&A. Anybody can put in. You have a girl who presents to us with dehydration, who has got a hyperkalemia, normal genitalia. What do you think is the cause that we're looking at? Anybody? So as discussed, if a girl has a normal genitalia, it cannot be 21-hydroxylase deficiency. And you have got a high aldosterone, so we are most likely dealing with a pseudo-hypoaldosteronism in that scenario. Now, what investigation? So again, Dr. Rajesh has mentioned PHA. Dr. Muthu also has mentioned pseudo-hypoaldosteronism as a cause. Now, the next question is, what investigation is a must in this patient for diagnosis? So before you label as PHA, anything else you would like to do in a simple level to exclude a possibility? Anybody? So you can also put on the chat box, you are diagnosing PHA. So you should definitely get an ultrasound done and a urine routine microscopy. Dr. Muthu again has mentioned that. So he's quite quick in terms of these aspects. Next issue is, what are the inheritance of type 1A pseudohypoaldosteronism? So we can carry forward. So inheritance, we discussed there are two forms of PHA. PHA 1A, which is severe, and PHA 1B or 2, which is basically mild. So usually if you have a severe disease, you will have a different modification. So you usually have a recessive form in that regards. Next question is, what treatment will you like to give in this scenario? So we can ask people to put up the treatment. So you can put out the key treatment that we can give in this scenario. So essentially what you're looking at is that you have a deficiency of effect of aldosterone. You give a very high dose of aldosterone, which will counter the effect. You give a lot of salt. You give a lot of bicarbonate, and that will give you the picture in that perspective, and that will help you out in terms of reaching that aspect. Now, next case, Dr. Manoj, I think, is there.
Yeah. So sorry, it was some technical error from my side. Yeah. So 5-year-old boy presented with the potassium 5.5 millimole per liter, and the BP is higher side. BP is 122 and 82 mm per Hg. And surprisingly, generally we see if there is a hyperkalemia, then we generally notice about the hypokalemia. But in this patient, sodium was around 145 millimole per liter. So my first question is, what will be the most likely diagnosis in this patient? So there is the hyperkalemia and there is the hypernatremia. So there is the only rare possibilities in this patient.
So I think this is something which has already been answered by Dr. Muthu, who seems to be winning this by a wide margin. Gordon syndrome, hypernatremia, hyperkalemia. Clearly, we are talking about a scenario which is basically in the setting of Gordon syndrome. Now, which is the genetic defect that Dr. Manoj is now asking?
So yeah, the question is, what defect can cause this kind of picture? So this is the Gordon syndrome, and why this defect has occurred due to in Gordon syndrome. So what are the genetic defects?
So it is the molecular channel which is affected. So I think if somebody had heard, Dr. Rajesh is also mentioning Gordon. So if somebody had heard Vibha, they would know exactly this is opposite to gentleman. So this is the, which channel are we talking about in Gordon syndrome?
This is sodium.
This is defect is basically WNT14, and which regulates the sodium chloride importer.
Sodium chloride importer is the defect. So what are the treatment, Dr. Manoj, in this scenario?
So yeah, for the Gordon syndrome, we have to basically manage with the thiazides. Gordon syndrome has a defect in the sodium chloride channel. So the thiazide block this channel, and it prevents the hypertension, and it causes the sodium loss. So it prevents the hyperkalemia. So main role of the treatment is thiazide.
Okay, so carry on the next question.
So, yeah, so we do have the another interesting case, which is the 6-year-old boy who presented in the ICU, basically with the tumor lysis, and her potassium is sky high, 6.3. And ECG shows a tall T wave, and patient was on AC inhibitor. So what should be the ideal first-line management strategy in this case? Should we have to stop the AC inhibitor? Second option is we need to start with the calcium gluconate. Either we should have to stop AC inhibitor with the calcium gluconate we need to start, or fourth option is furosemide. So among the four options, what is the best correct treatment strategy for this patient?
So Dr. Tolani is mentioning option C, which is very logical. Yeah. You have a child who has got a potassium which is between 6 to 7. There is already a ECG changes which are there. You have to give calcium, and you probably have to give other things like soda bicarbonate, salbutamol as well. And of course, if you don't stop ACE inhibitors, there will be a continuing problem. So Dr. Tolani is absolutely right. We have to start calcium and stop ACE inhibitors. And how does calcium work, Dr. Manoj?
Yeah, so calcium don't work to reduce the potassium, but calcium has a protective role on the cardiac stability. In this patient is presented with the tumor lysis, and there is an acute rise of potassium. So there is a high chance of the cardiac arrest. To prevent the cardiac protection, for the cardiac protection, we have to start the calcium gluconate, and the main role of the calcium gluconate for the cardiac stability rather than for hyperkalemia.
I think that's an important point to remember. Now, what will be the next step in management of this case? I think this, of course, we've discussed that you have to basically correct the underlying cause and manage that. Now, what is the next question you're asking for?
So after that, my fourth question is, what will be the total body potassium after calcium gluconate therapy and after the insulin dextrose infusion? So in this patient, suppose if we have started with the calcium gluconate and insulin dextrose strip 2 for the hyperkalemia, so what will be the total body potassium?
So you want to know whether it will increase, decrease, or be the same. So you can give these three options. Will it increase? Will it be the same? So yes, Dr. Rajesh mentioned they will remain the same. So basically, you're basically shifting the, so calcium gluconate is only protecting the heart. Whatever, even if you give insulin dextrose, you're pushing it in the cell. So total body potassium will be the same. Next question is the oral therapy option, which will be there. So Dr. Manoj, what is the oral therapy option?
So oral therapy we can give in this patient is action resin. Basically, it works, we can give via orally or by the rectal route. And what are the principle for their action? It exchange the sodium with the potassium. So it absorbs sodium and it secretes the potassium from the intestine. So these are the main oral therapy that we can use. And my sixth question is, how to reduce total body potassium in this case? Because giving the calcium gluconate and insulin dextrose strip, total body potassium will be normal. So how to reduce total body potassium, which is the essential step?
So which you have already answered that you can use, and Dr. Rajesh is mentioning furosemide is a good option. That's true. You can use furosemide, you can use dialysis, you can use exchange resins and all that regards. Now the last section is rapid fire. So we will quickly have a rapid fire. So you have to answer in the chat. So the first question, Dr. Manoj, quickly.
Yeah, so these all questions we have discussed previously. So for the brush up for the revision, what are the transcellular shift of potassium? Transcellular shift of the potassium is facilitated by which transport system?
So we are looking at responses.
So you can write in quickly.
Yeah, so anybody who writes quickly will announce a winner for this one. So which is the channel which basically exchanges the potassium? I think this is very easy. So sodium potassium ATPase, Dr. Rajesh has got it. Next question. It is perfect.
So what is the treatment for the hyperkalemia in the CH? So as we discussed, there is a specific treatment for the hyperkalemia according to etiology.
So CH, what treatment will you give? That will, of course,
so for the CH management is different.
So, of course, you have to give fludrocord along with hydrocort. And remember that fludrocord requirement may be very high in the initial phase. Next question, hyperkalemia and renal failure. So,
how to manage the hyperkalemia in the renal failure? So, it is the very particular management.
So this is a bit confusing. I believe what you want really in that regards, Manoj.
So yeah, so for the management of the hyperkalemia in the renal failure, we have to start with the soda bicarbonate. If patient is stable, and then we can shift towards the dialysis, because the dialysis is only treatment. So
ultimately, dialysis will be the main treatment, as Dr. Tulani is mentioning. But
yeah.
soda bicarbonate, because they will also have acidosis, that will also be a much more effective way to go forward. Now, this is a tricky question. So what are the formula for transtubular potassium gradient? So even if you tell me what are the things required to assess kg, that's enough. So what measurements you will do, forget about the formula. So quickly, we of course want the urinary and the blood potassium. What else do we want? So other than urine and blood potassium, what else is required for TTKG calculation? So you are looking at urinary potassium, you are looking at serum potassium. So urinary potassium upon serum potassium divided by, you need to have so you are comparing potassium excretion to osmol excretion. So you need a urinary osmolality and a plasma osmolality. So Dr. Mothu has already written. So this will give a clue in that perspective. So this has been a wonderful aspect with regards to the question and quizzes to summarize the entirety that we've been discussing. Thanks, Dr. Manoj, for that. We are coming to the close of our program. So we will now just summarize the whole scenario. And so as discussed, hyperkalemia is something which is extremely important from an acute perspective. Usually it is because of a renal dysfunction, but you can have transcellular shift as well as some drugs which can cause that. Acute management is very important to use calcium gluconate along with soda bicarbonate and other options. And if you manage chronically, you have to assess for renin and aldosterone, which will give you the clue. So we'll summarize the session and we'll close it now. So all of you can go and have a look at our website, look at our application and publications. And we have this monthly sessions, which are ongoing every month. So at the end, I'd like to thank Dr. Vibha and Dr. Manoj for the wonderful discussion that they had in terms of the various aspects of the pathophysiology, evaluation, etiology, and management of hyperkalemia. I'd like to thank all the attendees who were there from across the globe for this program. We'll be uploading the sessions on the YouTube as well as our own website as well. So any closing remarks from Dr. Vibha first?
Sir, it was a wonderful session, and I would definitely give you a lot of thank you for giving me this opportunity, and thank you so much.
You had presented very nicely about etiology, and Dr. Manoj, you presented very nicely about the cases and scenarios. Any closing thoughts on hyperkalemia?
Yes, sir. So thank you very much, sir, for giving the opportunity. And I would like to say that etiology, to knowing the etiology of hyperkalemia is very crucial. So if we do proper management, then we can prevent the cardiac arrest. So the proper and acute management is mandatory from the pediatric perspective.
So if you identify hyperkalemia, half of your battle is already won. If you miss hyperkalemia, you can't do anything. So very important is to know which child may develop hyperkalemia. Put an ECG monitoring there so you identify it immediately quickly. Correct all the reversible causes. So your main aim is to prevent hyperkalemia. So you have to basically look at the drugs which can worsen hyperkalemia. If somebody has renal dysfunction, you have to be more cautious. And if you prevent, that will be the way forward. So I think we like to close at this point of time. Thank all of you for being part of this program. And we will have the next meeting next month on another aspect of the postgraduate lecture series.